And my focus today is going to be on late complications, and a lot of this you've seen in the previous slides or from the previous talks, but I want to sort of repackage it, and this time really focus on the late complications and what we do every day as far as transplant cardiology and how our focus changes over time with each patient. So I have no conflicts to disclose. And so this is from the recent ISHLT report, register report, and this is sort of a recap of what we're seeing in the US as far as transplantation goes. So it's good news, bad news. Transplant volumes are up, but it's up due to the opioid epidemic that we're experiencing right now in the US. Also in the US, the recipient age remains in the 50s. And what we found in the recent report is that the recipients actually have more comorbidities. So as Dr. Eisen showed you in a previous slide, they're coming to transplant sicker, and they're also coming to transplant with a lot more hypertension, diabetes, and even prior malignancy. So we've sort of loosened up on the candidates for transplant. Also, we know that the median survival has improved for transplant in this current era. As we've heard before, we're doing really well with treating, we're actually avoiding patients from having acute rejection. And this is really the most interesting spin that we have in the US, unlike here, but half of our patients are actually bridge patients by the time they get to transplantation. So mechanical devices are now put in almost over 50% of our candidates. And you've seen this, and it's worth showing over and over and over again, that as transplant cardiologists, we have to deal with malignancy, graft failure, infection, as the leading causes of death later on. So this is just a slide showing our recipients, or actually candidates / recipients as they're going to transplant. And I was a little bit surprised to see this. About 15% of our candidates have diabetes in the early era, and now we're up to almost a quarter, or 26% of them have diabetes going in. Hypertension, about 50% of our candidates have diabetes, and prior malignancies is now up to 8.6%. So even though our survival is better, we're transplanting patients who have more comorbidities going in. And this is just a slide you've seen before. Purple is the current era, and it shows that decade over decade, we're doing better with our survival in our transplant patients. We've seen this before, so in terms of acute rejection, cellular rejection, it's now almost a surprise to see it. And this is the slide which I find the most interesting, and this is the use of bridging candidates to transplant. So in 2005, it was a little bit over 25%, and now we're over 50% of the patients are actually bridged going into transplant in the US. Now, you might say, well, is that going to be a problem on the post-transplant side? If 50% of our candidates are actually bridged, what's their survival look like over time? And so what we see here, if you're comparing outcomes in terms of patients who are bridged, and this is interesting too because of our new allocation system actually prioritizes ECMO patients. And if you look back in the registry data, those are the patients who actually do the worst going to transplant. So once that new allocation system was approved, there's a plan to relook at outcomes every 6 months, and we'll see if that was actually such a good idea because we know that ECMO patients don't do as well as other patients who go into transplant. So what we've heard earlier is that as patients move from their transplant date to later on in time, we have to sort of switch our gears from dealing with acute rejection and infection during the first year to surveillance for cancer and transplant vasculopathy, which we'll talk about. So this is just a slide that you've seen before, but it really depicts what we're referring to. So early on, you have acute graft failure. Sometimes acute graft failure they thought was related to patients who were bridged. It's really not quite clear why that's happening, but we have acute graft failure, we have multisystem organ failure, and of course infection. That's all early on. When we get out to later, we're down to malignancy, graft failure, and infection. And graft failure is actually a very interesting concept to me because we have so many patients who have graft failure without angiographic evidence of calves. So I'd like to know from the pathologist what they're actually seeing. So in terms of complications from transplant, as we've shown that the morbidities that we're concerned about actually increase over time and are different compared to our earlier on. And so Dr. Eisen showed you this, where about 23% of the patients who are 10 years out from transplant have renal dysfunction. 47% of them have transplant vasculopathy. So our focus of what we're doing as transplant cardiologists is different in survivors. In terms of malignancy, we've heard this over and over again. As patients survive years of transplant, they now are at high risk for developing malignancy. So at 10 years, it's about 28%. So as we've heard that actually our transplant medications, the medications that make transplant possible, are also the culprits into people developing malignancy and graft failure later on. So this is also from the recent report, and it shows, as it has over all areas of transplant, that later on, graft failure, infection, and malignancy are the things that cut a transplant patient's life short. And now I'd like to focus on the recent data. And some of these slides you've seen before, but this is from Dr. Yoon, who's in the audience today. So in terms of, we know what the late complications are: malignancy and graft failure, CAV. What can we do as practitioners to actually combat this? And so that's what the next part of my talk will be about. But this is actually the only bad news story that we have in transplant. From Dr. Yoon's analysis, he was able to show that actually malignancy rates are increasing in transplant recipients. And as we've heard over and over again, survival in patients who develop a malignancy is worse than those who do not. Do this. We also heard from Dr. Eisen about cardiac allograft vasculopathy. And as we've heard, survival in patients who don't have vasculopathy is better than those who do. And what we see now in the current era is that the incidence of CAV is actually decreasing, which is good. Get away from that. Okay, so let me get to the meat of the talk, and that is, what can we actually do now for our patients to hopefully minimize the development of malignancies or transplant vasculopathy? As we've heard earlier, we know that surveillance is key for looking for malignancies, but is there anything we can do up front to decrease this from occurring? So this is actually an analysis of comparison of patients who are treated with tacrolimus versus those with cyclosporin. This is also from the registry, and what they found is that patients who are on a tacrolimus regimen actually have fewer malignancies than those who don't. So at this point, as we've just seen through the registry report, the use of cyclosporin has actually dropped tremendously worldwide. Part of that has to do with fewer rejections, and also we now see that these patients are more likely to develop malignancy than those on tacrolimus. Okay, so this, I'm not going to go into detail. This is really a synopsis of what Dr. Eisen was saying. And from this author, they're actually referring to calcineurin as cardiogenic because of what we've seen on previous slides. And mTOR inhibitors are thought to be not carcinogenic. And we heard that from Dr. Eisen's synopsis also, in terms of it stops the cell cycle and actually tumor growth. So there's a lot of interest for using these agents early in transplant and then in maintenance. And we'll go through some of the data that Dr. Eisen just went through. So in terms of the use of sirolimus in patients regarding malignancies, this is also a nice summary also from that same group at the Mayo Clinic. And this includes about 600 patients. So what they looked at were patients who they switched as usual care because they were trying to minimize renal failure. And then over the long term, they looked to see, well, what did this actually do to cancer rates in these patients? And what they found is the patients who were switched mostly about a year after transplant had fewer malignancies in terms of non-skin cancers, PTLD, and also recurrent skin cancer. So it didn't seem to decrease the rate of skin cancer development, non-melanotic, but it did decrease the recurrence rate. So this was a long-term study. So we've seen a lot of prospective trials where patients are placed on mTOR inhibitors earlier on, but this is a case where the patients were put on mTOR inhibitors because of renal dysfunction, and then they went back with long-term follow-up and saw that this was actually beneficial in terms of the development of malignancies. In terms of the cancers that they saw in transplant patients is what you would expect: PTLD, skin cancers, and solid organ tumors. So what they found in this particular trial is that patients who are on calcineurin inhibitors as their sole calcineurin inhibitors over time had more malignancies than those who were on the CNI-free regimen. we sort of saw this. I'm skipping through this because we sort of heard these before. So their overall survival for patients who were on the sirolimus regimen was significantly better than those who were on the calcineurin inhibitors. And that was overall survival and also malignancy-free survival. And then the next one is, of course, CAV. And so this is from that same group of cohort of patients. So remember, they were placed on calcineurin-free regimens early on because they were trying to deal with renal insufficiency. And what they found out also when they looked at these people over the long term is that patients who were switched to calcineurin-free regimen had a lower risk of developing CAV. Those who were switched later on had an intermediate risk, and those who stayed on calcineurin inhibitor-based regimen had a high risk of developing CAV. And so this slide shows you in terms of all causes of mortality. And this slide actually shows that the calcineurin-free regimen favors in terms of cardiac death and is also harm CAV-related events. This is also a slide that you saw before, which shows the incidence of developing CAV in this group of patients. The patients who were on calcineurin inhibitors had the highest risk when compared to people who were switched early versus at an intermediate time. So this is really, for me, a study that's sort of making me think how to change my practice. So what you'll see is that mortality for people who are on the calcineurin-free regimen did not suffer in terms of rejections or mortality. They actually had a better outcomes. And also with the development of malignancies and CAVs, it seemed to a sirolimus regimen-based regimen was actually superior to that of a calcineurin inhibitor regimen. So in terms of a wrap-up for this, we know that as patients move out from surgery, that our focus as transplant cardiologists has to change from dealing with infection and rejection and sort of hemodynamic complications of the transplant procedure to the end to maintaining a balance between our immunosuppression. So at some point, when do we switch? I was actually very hesitant early on to go to a calcineurin-free regimen because just anecdotal evidence, I've seen patient have rejections. But now with the Mayo Clinic data, long-term data, I think switching people to sirolimus-free regimen, to a calcineurin-free regimen is actually going to be very important to hopefully decrease malignancies and CAV over time. So just to do my conclusions, we know that transplant recipients succumb to adverse events really due to the immunosuppression regimens that we use. We know that long-term survivors are more at risk to develop cancers at a pretty alarming rate. There's also infection remains a risk for patients because of being on immunosuppression, renal failure, and also transplant vasculopathy, which is unique to our set of patients. The mechanisms for late graft failure and transplant vasculopathy are not clearly understood, but we do know that some of it is immunologic and also non-immunologic. But at this point, we have several strategies to hopefully prevent the development of these complications. The first one, which I can't say enough about, is just trying to decrease overall immunosuppression exposure to patients. That's probably the most critical. And then we want to now look at calcineurin-free regimens, which we've seen on the previous slides, improves renal function, decreases the risk of CAV, and also decreases the risk of developing a malignancy. And with malignancies, of course, we have to have vigilant surveillance. So I find myself sending people for mammograms and colonoscopies, things that you think the primary would do, but ultimately it becomes our responsibility because we know the adverse effects of the medications that we use. And then finally, you can't say enough about just overall CV risk factor modification because we know a lot of our recipients are going in with baseline risk factors for cardiovascular illness. And I'll stop there.